Next talk, refractive surgery in glaucoma patients by Dr. Yomna Abu Bakr.
So today we're going to talk about refractive surgery in glaucoma patients. So refractive surgery is most commonly used to treat myopia, hypermetropia, and astigmatism. Okay, depending on the refractive error, the cornea is made to be flatter or steeper. This is well known. Some of the most common procedures are LASIK, PRK, SMILE, and ICL. Glaucoma is a chronic progressive optic neuropathy, results in morphological changes at the optic nerve head and retinal nerve fiber layer, progressive retinal ganglion cell death, and visual field loss. IUP is a key modifiable factor. So what's the relationship between glaucomatous patients and patients seeking refractive surgery? Myopes are more likely to seek refractive surgery. Prevalence of glaucoma among myopes is 2 to 4 times higher. It increases with higher levels of myopia. High myopes are predisposed to primary open-angle glaucoma. Post-operative considerations to consider in a patient with glaucoma is decreased corneal thickness, which leads to underestimations of the IOP, use of steroids, and in phakic IOL, it sometimes increases the IOP if the patient is already predisposed or a glaucoma suspect. So in order to deal with any patients, we have to conduct a stepwise approach in managing a refractive surgery patient. This consists of 4 steps: preoperative assessment, proper choice of the procedure, intraoperative management, and postoperative management. Preoperative assessment consists of history taking, comprehensive ophthalmological assessment, unaided and corrected distance visual acuity, slit lamp examination, fundus examination, IOP, central corneal thickness and axial length, topography and wavefront analysis, gonioscopy and anterior segment imaging, optic disc photography, visual field, and OCT. The most important thing in history taking, if the patient is a glaucoma suspect, if he has a family history of glaucoma, if the patient is diabetic, if the patient is hypertensive, they have an increased risk of glaucoma. So the risk-benefit is discussed with the patient, together with counseling of the patient, and informed consent is written. To start with the IOP, which is the most important factor in refractive surgery patients. So the Goldman applanation tonometry is the gold standard. It applanates 3.06 diameter, and it's based on a CCT of 520 microns. So what's the problem with the Goldman applanation tonometry after the refractive surgery? This leads to the underestimation of the IOP, except in phakic IOLs, because we don't play with the corneal thickness. And Rashad et al. Recommended that with every diopter of myopic correction, 0.5 millimeters should be added to the measured IOP. And Imara et al. Found that for every 37.8 microns decrease in CCT, there is a 1 millimeter mercury reduction in IOP. Of course, we all want the patients to be happy while measuring the IOP like this patient, but that doesn't happen. More accurate alternatives for post-refractive surgery are the air puff, because the air puff and the tonopen have smaller areas of applanation, are less affected by the corneal properties than Goldman applanation tonometer. Garzosi compared the IOP measurements on the temporal non-ablated part of the cornea with the tonopen, Goldman applanation tonometry, and non-contact tonometer, and they found that the tonopen is the most accurate of all. There's something called the dynamic contour tonometry, which matches the surface contour of the cornea, removing the influences of the corneal property and giving an accurate measurement, which is the picture bottom right. So basically they send waves and it measures, it's an automatic measurements, and you have an LCD screen measuring after 6 waves, they measure the IOP. And this is the most accurate of them all. The next thing is gonioscopy. Gonioscopy is not done as a routine, but it's done in some cases, like in cases of hypermetropia with shallow AC, especially if the patient is going to do a phakic IOL. It can be combined with anterior segment OCT in a patient with positive family history or a glaucoma suspect. Pigment dispersion syndrome is suspected, like this picture here. In patients scheduled for phakic IOL with a suspicion of angle anomaly, like previous trauma with angle recession, peripheral anterior synechia, and in post-phakic IOL pigment dispersion. Another thing that's oftenly missed and we don't do is optic disc photography. Optic disc photography is particularly important in myopia because it's often challenging to assess a myopic disc due to tilting of the optic head, large optic disc with shallow cupping, and the presence of the characteristic present peripapillary atrophy. Preoperative baseline optic disc photography includes the one with the red-free filters, so we can compare and assess suspicious disc as well as monitor the discs over time. Visual field assessment. Again, myopic eyes may exhibit abnormal visual fields, such as enlarged blind spot, paracentral defect, or rarely defects in the arcuate area, like the examples on the right. These anomalies can arise due to the tilt or the torsion of the optic disc, extensive peripapillary atrophy, chorioretinal atrophic areas, or even in the absence of glaucoma. Preoperative visual field acts as a baseline and helps us define new defects that, if the patient progresses to glaucoma because they're more susceptible to be glaucomatous, then we can assess the preoperative and postoperative data of the patient. So the most important thing in any glaucoma suspect or any patient undergoing refractive surgery in general is to assess the eye. Eyes at risk for glaucoma, PRK is more suitable for them than LASIK, especially if there are smaller degrees, they don't have high degrees of astigmatism, to avoid interface fluid syndrome. However, the duration of topical steroids with PRK is prolonged, so you have an increased risk of steroid respondence. So it's better to start with something like lutiprednol than Optipred, prednisolone, or fluorometholone even. If LASIK is considered, then it's not advised in patients with already established glaucoma or glaucoma suspects because we have a rise to up to 60 millimeters mercury. The alternative is for them to go for femtolasic, which rises between 14 and 30 millimeter mercury max. Patients with glaucoma suspects or with a strong family history of glaucoma may not be candidates for good candidates for phakic IOL and may be at a higher risk of postoperative IOP elevation. So what are the causes? This is a diagram just illustrating the causes of postoperative IOP elevation in different situations. So in PRK, the most common cause is a steroid responder. And if you didn't assess the patient well, then he probably has a pre-existing glaucoma in some cases. In LASIK, femtolasic, epilasic, and SMILE, if it's intraoperative, it's due to the suction ring. If it's postoperative, again, it's due to steroid respondence, pre-existing glaucoma, secondary glaucoma, if the patient had the previous retinal detachment surgery. But again, this can easily be avoided if you properly assess the patient from the start. In phakic IOLs, in open angles, if you have a phakic patient with open angle, the most common cause is retained viscoelastic, especially in the early postoperative period. If the patient is a steroid responder, and we find that patients undergoing phakic IOLs, they're already high myopes. Most of them are steroid responders, so again, you can avoid that by switching to lutiprednol from the start and avoiding prednisolone. And pigment dispersion syndrome and pre-existing glaucoma. Angle closure, it's a bit, if it's improperly sized, if it's a large size, if there's a pupillary block, but this is avoided in the new versions because you have a central hole, if you have malignant glaucoma. So how to avoid the post-operative spike? You can do proper pre-operative screening and planning, minimum use of cohesive viscoelastic instead of adhesive viscoelastic, use of luticretinol instead of prednisolone eye drops to avoid this IOL spike in steroid responders, and the take-home message in any refractive surgery patient, again and again and again, proper assessment, proper pre-operative planning, proper measurements of the, especially in phakic IOL patients, so you don't have a largely sized phakic IOL, and the use of minimum steroids or alternative steroids to prednisolone will avoid most of the problems that we face. Thank you.
Thank you, Dr. Lom. دكتور يوم سوري. اعتقد ان الدكتور ايمن جماعه الدكتور ايمن اعتذر، فغالبا هتبقى دي اخر محاضره. وطبعا التوبيك بتاع ريفراكتيف سيرجري في جلوكوما بيشنت يعني بنلجأ له في حالات محدوده جدا، ليميتد بيشنتس، لان طبعا هيتعرض يعني مثلا السكشن رينج هترفع له التنشن، البوست اوبريتيف ستيرويدز هيرفع له التنشن، لو هيركب اي سي ال هو ممكن اوريدي يبقى انجل كلوجر، فطبعا مش هينفع الاي سي ال، لان هو موضوع شائك جدا يعني ده في حاله بقى لو هو ما ينفعلوش بقى نظاره وكونتاكت لينس برضه هتضايقه، يعني هو ده الحالات اللي هي بقى غلب حمارنا يعني خلاص لازم يعمل كده، فمضطرين يعني، وناخد بقى بريكوشن بتاعتها اللي حضرتك ذكرتيها دي حاجه كويسه طبعا. هو موضوع شائك جدا يعني، بس يعني ساعات بنبعد عنه تماما. ودلوقتي الاوربي سكان او البنتا كام بيكتب تحت اما بيعمل الثيكنس بتاع الكورنيا تقللي قد ايه من الميجرمنت لو قسيها بالابلانيشن اوتوماتيك، بقت بتتعمل اوتوماتيك دلوقتي، حتى لان هو اوريدي اول ما بيشوف الكورنيال ثيكنس يعني كالكوليشنز كده اوتوماتيك موجوده في الجهاز نفسه، بيقول لك مثلا ايه قللي درجتين قللي 3، ده موجود في الاوربي سكان كله. طبعا طبعا يعني المفروض الدكتور المعالج بتاعه بيبقى عارف الموضوع ده. يعني موضوع شائك جدا يعني. بالتالي احنا كده خلصنا، وكل سنه وانتم طيبين، متشكرين جدا، نورتونا، ونشوفكم السنه الجايه ان شاء الله، كان لنا عمر.